This week on the BackTable podcast.
Follow the guidelines, follow the rules, make sure you're properly diagnosed and classified. If you can send it for genetics and you're in a center that does that, do that. It's not so easy always to get genetics from these. And, realize that I suspect that other than small and local lesions, I think in 15 years, IR will have a minimal role. Like we will be the people you bring in at the end to clean it up or to deal with the things that drugs can't handle. So I think that's sort of where we're going to live. I tell people, don't be afraid, stick to your training. You don't need to use the force, just use good imaging, use the right drugs, use the right medications, and kind of know what you're doing. And don't hesitate to put safety measures in place, like anesthesia when you need it. But always, if you need to ask for help, that's what the centers are here for. Like this is what we do for a living.
RADPAD was developed by physicians for physicians. Clinically proven radiation protection during cine and digital subtraction angiography. Don't bet your career or your health on anything less. Trust RADPAD radiation protection shields for all your fluoro-guided interventions. See radpad.com for more information and contact info@radpad.com for a free radiation evaluation and a no-brainer radiation protection cap. And don't forget to tell them that you heard about it on the BackTable podcast.
This is Mike Barraza, returning as your host. I am pleased to welcome, or I should say welcome back, my friend Dr. Cliff Weiss at Johns Hopkins. We've done this a couple times with this. We talked about bariatric embolization, and then we talked about hereditary hemorrhagic telangiectasia and pulmonary AVMs. Today, we're going to spend some time talking about vascular anomalies or vascular malformations. Cliff, you wear a lot of hats at Hopkins and SIR in general. What's been going on with you?
Oh, things are going well. It's a busy year, busy season. Thanks for having me back. This is another topic which is very near and dear to my heart. Yeah, no, things are good. We're busy. Summer's a busy time in the Vascular Anomaly Center at Hopkins because we have a lot of children a lot of kids that come through and they want to get treated, in between school, or their parents want them treated in between school. So where other people get to take a break, we kind of ramp up a little bit over the summer.
I'm doing a lot of osteomas this month.
Absolutely.
For the same reason.
Yeah.
That's cool. So one of your many roles is as the director of the Vascular Anomaly Center at Johns Hopkins. How long have you been doing that?
Yeah, so I kind of got interested in this field as a medical student. And the Vascular Anomaly Center, we're one of the earlier centers in the country. And it was really started by my mentor, a really just compassionate and brilliant interventionalist named Sally Mitchell. So she was running the center when I was a med student, and I got really excited and interested in this topic and kind of took this over in 2018 when she retired. It's a ton of fun. It's a very diverse and interesting practice. I mean, I got into this originally because when in the late 90s, early thousands, we would see patients come into clinic who had been banged around by the medical system for 10, 15 years, told they had cancer, irradiated, operated on, told they couldn't be helped, or given the wrong diagnosis. And to see those patients kind of transformed by a visit to an interventional radiologist with a diagnosis and a treatment plan, a death sentence that had been removed, really was pretty special. Also was a pretty rare field at the time. Late 90s, early thousands, not a lot of people were doing this. So it gave me a chance to have a big impact pretty quickly. The center has been running now. It's one of the longest running centers in the country, probably somewhere in parallel with the other kind of well-known centers like Boston Children's and CHOP. So, we've been doing this for a long time.
That's really cool. You've been the director for a while now, right?
Yeah, since 2018. Yep.
Who else is involved with evaluating patients and treating them at the Vascular Anomaly Center?
Yeah, so any kind of well put together vascular anomaly center has a large multidisciplinary team. And I've lost count of the number of people because we treat people from childhood to senescence. So we're one of the only centers that will treat you from birth to death, really. And so critical to the center are dermatology, pediatric and or adult, hematology these days, genetics, oncology, surgery, plastic surgery, ENT, kind of high-end diagnostic imagers who know what they're doing and know how to read these images and really help deliver a diagnosis. Right now, there's like 47 people, I think, who are part of the center. Yeah.
Is this a standalone building, the Vascular Anomaly Center?
It's not even a funded entity, my friend. This is all done for passion. This is not done for, no, we're not a standalone entity. We are, generally people will see me or dermatology as the entrance point, and then we'll get distributed to other services as needed. Often they'll come in through ear, nose, and throat because a lot of these will happen in the head and neck. And at this point, we have a multidisciplinary meeting once a month for an hour, hour and a half by Zoom. The complicated patients are discussed and a treatment plan is set up. But I'd say that most of the patients come through interventional radiology. So every Monday, I have a pediatric clinic from 8 a.m. till noon and an adult clinic from 1 to 5. And we'll do, probably about 12, 14, 15 kids in the morning, about 10 or 15 adults in the afternoon, a mixture of follow-up and new visits. So,
man, that is crazy busy, but also a really great experience for your trainees. Most people get some exposure to treating these during fellowship. Not everyone gets some. I was fortunate to get a good bit having worked at CHOP, but it is still something that, when I get a referral for it, they still make me a little nervous. Most pediatric cases do. I would imagine, in fact, I know I have personally sent someone to your clinic before. I would imagine you get a lot of referrals from places, from patients that are traveling, that are not necessarily in the Hopkins system. And so what I wonder is, for those patients who are coming from elsewhere, say like the patient that I sent you from Baton Rouge, what are you hoping to get for imaging before they get in the door? Or what else do you need?
So I like to say to patients that, I like to say a lot of things to patients, but I like to say to people is that with the right MRI and a clinical exam and a history, we can get you the right diagnosis between 90 and 99% of the time. So the MRI that I need, that we've been protocoling very similarly for a long time, the critical concept is 3-planar fat saturated or inversion recovery T2 weighted imaging. And that's going to be and you don't want a giant field. You want to keep the field pretty tight on the area. You want to see the relevant anatomy, but if I'm looking at a knee, I don't need to see the ankle and the hip. I need to see the knee. And so I need those images. I need a dynamic contrast enhancement. So we call it a twist. There are different names, different vendors, but essentially it's a real-time injection that you can watch the contrast move from kind of the venous inflow to arterial, then venous phase, and then delayed. And delayed contrast imaging as well. And that's all T1 weighted. And so that's kind of projection view, real-time MRI, dynamic contrast enhancement, post-contrast imaging, T1 weighted. And then I also do a few other things. I like diffusion. So I like to look at what the diffusion is, but some of that's from my own radiomics interest and not necessarily 100% on the diagnostic side. But if you can give me triplanar T2 fat sat that's really well done, so not, a mixed fat sat where you sort of miss it, but really, fat saturated. You can give me that dynamic image and you can give me post-contrast, and I can get you in for a history and physical. I'd say high 90s were done at the end of that. So, and when people say to me, why do you make me get this 90-minute incredibly difficult MR when I already had one that my orthopedic surgeon gave me? What I tell my patients is, and I think my PA is ready to kill me after having said this at least 3,000 times, is that MRI isn't taking pictures. MRI is a conversation. CT is taking pictures. X-rays are taking pictures. MRI, you ask questions of the body, and the body answers those questions back. If you don't ask the right questions, you don't get the right answers back.
That's right. I like that.
That's the conversation I have with the patient, is we're having a conversation. We're not taking pictures.
You talk about, over 90% likelihood of making a confident diagnosis. What diagnosis are you trying to make? Like, how important is it to classify these vascular anomalies prior to treatment?
Right. So to me, this is the most vital component. If you have the wrong diagnosis, you're treating the wrong lesion, you're going to do potentially the wrong thing or even damaging things. At a minimum, you'll do something that isn't helpful, which just makes everyone's life unpleasant. At a maximum, you can actually hurt somebody or puts people through truly unnecessary procedures. I can't tell you the number of times people come in with an angiogram that they've received for their malformation that was called an AVM, but it's really a venous malformation, or it's a lymphatic malformation, or it's a hemangioma. And so you need to have those diagnostic criteria down. And I will tell you, twice maybe 3 times in the last decade and a half have I done a diagnostic angio for something that I didn't know up front was a high flow lesion like an AVM or an AV fistula or even, a hemangioma, which frankly, I don't think I've done an angiogram for hemangioma either in 15 years. So very rarely will I put a patient on the table for a diagnostic angio unless I'm doing procedure planning for an AVM embolization.
Okay. Would you mind just briefly walking us through the classification of the different types of vascular anomalies?
So I'll do it how I do with my patients because there's a wonderful website. So the ISSVA just redid their classification. So that's the International Society for the Study of Vascular Anomalies, ISSVA. So if you go to their website, they have a wonderful classification table that I think they just simplified. I haven't gotten to go through it, but they just had their meeting and simplified it because it was 45 pages loaded with genetics. So they've brought it down. And there's a great paper that I pretty much is my Bible, and that's the S.E. Mitchell classification schema. That's Sally Mitchell, my mentor. Her classification scheme. It's a fantastic paper that goes through the imaging and the clinical findings and takes you through a flow chart. And so those are great resources that I would say, if you're going to do this, you should really look at those. But let me take you through the basic classification. And this is really, everything now is classified by genetics and pathology. I kind of have a very basic clinical schema. So there's vascular anomalies. That's the overall arching title. And then under that, you have vascular tumors and you have vascular malformations. Vascular tumors are not always scary. Most of the time, they're not. They're some type of hemangioma, which is a true vascular tumor where the MRI will show you it's T2 bright, and then it really diffuses, it perfuses like a tumor, rapid increase, and then persistent enhancement. And it's pretty uniform. And then you would break that hemangioma into infantile hemangioma, showing up soon after birth, and then rapidly involuting, as it sometimes is helped with things like propranolol. And then congenital hemangioma, which children are born with, and those can either be non-involuting, partially involuting, or rapidly involuting. So niche, piche, or riche. It was described by the French, so we have a French accent. So that's the tumor. And then there are scary things like hemangiosarcomas, and most patients don't make it to me with one of those. They're usually cleared out very quickly. If I see a benign lesion with a tree-like branching pattern that fits those diagnostic criteria, I might take a biopsy if I'm going to ablate it, but otherwise I tell you that's a hemangioma, it's benign, we're good to go. That's the tumor side. Then on the other side, there's the vascular malformation. So anomalies, vascular tumors, vascular malformation. Under malformation, you have essentially 2 branch points, high flow, low flow. High flow contains arteries, and there really are, in my mind, only 2. An AV fistula, where you have a 1-to-1 connection of an artery to vein, often traumatic the patient doesn't even recognize. They don't know that they were traumatized. And then AV malformation, where you have either a classic vessel tangle like a nidus, where arteries and veins come together in this kind of ball of Medusa's head of blood vessels, or you can have kind of a diffuse nidus and kind of a microvascular AVM. But that's your high flow lesions, AVM, AV fistula. And really, the other part are the low flow malformations. And MRI is going to get you to tumor, high flow or low flow, if you're done properly most of the time. On the low flow side, there's capillary malformations, which are red things on the skin, and usually dermatologies grab those already. They can be pretty bad, and they can cause bone loss, and they're not really very treatable deep, but that's capillary, and they're not usually, honestly, something that I'm managing. I'm getting them to the right people, but they're not necessary for me to manage. That leaves us with venous malformation and lymphatic malformation. And then venous is classified, in my mind, in kind of 4 types, kind of the non-draining vein, small draining veins, larger or more numerous draining veins, and then venous ectasia. And then there's the lymphatic malformation, which is either large cysts, macrocystic, small cysts, microcystic, or mixed. And then there's a gazillion different mixtures of all these malformations because we now know genetically they interrelate. I try to keep people as solidly in one classification as I can because that's then going to direct the therapy. And again, MRI, non-enhancing except on the venous phase, kind of slow, is going to be a venous malformation. Non-enhancing with delayed contrast, only seeing the rim of the thing, that's going to be a lymphatic malformation, except microcystic can look diffuse because the little cysts will enhance. So, and then phlebolyths are found pretty much only in venous malformation, right? So when I start seeing phlebolyths, I'm heading way towards venous malformation quickly. And the reality is if you, Mike, walk into clinic and throw a stone at a patient, right? 99 times out of 10, don't throw stones at your patients. Okay, don't do that. But if you were to walk in and just point at somebody, 9 times out of 10, it's a venous malformation because they're really common. Very rarely will they be lymphatic, and then they'll define themselves pretty quickly on imaging clinical exam. And then even more rarely will they be an AVM or a hemangioma. Ultrasound is really helpful. If I've gotten the wrong MRI, I will start with an ultrasound. If there's flow or no flow, that gets me to high flow versus low flow malformation pretty quickly, if I need to do that.
Let's talk about how you treat them, which I know is very complicated because they're very different. So let's start with the vascular tumors. In which circumstances are they being sent to you for therapy?
So oddly enough, I've had a rash of adults that have shown up with hemangiomas kind of later in life, and they probably were always there and then got stimulated in some way. Trauma, sometimes hormonal changes, I think, will affect venous or lymphatic malformations, and AVMs. I think they probably affect hemangiomas as well. Generally, the skin level lesions are going to be treated with, so first of all, infantile hemangiomas are going to be medically managed. You're going to give them beta blockers and they're going to melt away. And then afterwards, surgery will come in and clean up any superficial lesion that is kind of left a defect. Congenital hemangiomas in a baby may rapidly involute, and they can look scary. They can look like AVMs in a little baby. So we try to give them some time, or they may not involute or partially involute. So generally, if there's a residual mass or there's a newly described mass, it's causing some type of functional deficit or pain, then they will kind of call me in to treat. And at this point, I pretty much ablate these. So I'll get them on the scanner. I'll either do it under MR guidance. Pretty much now at this point, I do everything under CT or ultrasound. I'll biopsy the lesion first just to make everyone comfortable. Most have been biopsied by orthopedic surgery at least twice already, in which case I'm not doing the biopsy. And by the way, on the biopsy, they never get the diagnosis right. Everything's a hemangioma or an AVM. They're never right. So as long as it's not malignant, I don't care about anything else on the biopsy results for these lesions, unless it's an expert pathologist who's done the proper staining, sent it for genetics. If it's just a benign versus malignant, and it looks like a hemangioma, it acts like a hemangioma, I'm going to ablate it. And I'm not looking for a complete removal of the tumor. I'm trying to take as much as I can and keep the normal tissue as preserved as possible, because that's when patients are kind of miserable. If you're doing a thigh hemangioma and you do a big old ice ball that killed the whole thing, but you're really taking 5 millimeters on all sides like you would for a renal tumor of quadriceps, they're in pain for 2 or 3 weeks and they're not happy. If you just take the core lesion, you can leave a rim. It's not cancer, right? And so who cares? You come back later and treat it, or you don't, because you're doing this on symptoms.
You're doing mostly cryo?
Yeah, I do cryo. I have friends who do laser. I like cryo because I have control. I can dial it up, dial it down. I don't need full kill. Cryo is a nice method for this. So that's hemangioma. On the other side is where, I think that's where chaos starts. Oh, by the way, I've done an angio for the hemangioma. I've not tried to embolize the hemangioma. I just ablate the hemangioma, right?
Yeah, I like it.
Okay, so on the other side, you've got our high and low flow. So let's start with the low flow. So let's go with lymphatic. So my world has shifted over the last 15, 20 years, where when we started, it was interventional radiology all the way, arguing with surgery at these meetings. And you'd listen to the old guard get up in there and kind of yell at each other over what agent to use. And now the meeting is totally shifted to the genetics and the hematology and the oncology, because these are now kind of kissing cousins of cancer. They're not cancer, but they share the genetic pathway of a lot of cancers, And so sometimes we'll treat these, if they're large and they're kind of unwieldy, with systemic medication before we ever get to any type of sclerotherapy or embolization, and then we'll come in afterwards and clean up a little bit. But that only is happening when they're kind of big and extreme. For smaller lesions, we're going to treat them with sclerotherapy. So for lymphatic, let's say it's macrocystic. I will do one of two things. If it's really big enough that I can park a little Dawson-Mueller 6 French catheter in there. I will drain it, and then I will fill it with, 50 to 60% volume of doxycycline.
Okay.
I'll let it dwell for 4 hours. I'll admit the patient, and then I'll do serial doxycycline exchanges every 8 hours.
Okay.
And that way I do one procedure, keep them for 2 days. I get a series of sclerotherapy. When the volume drops so that I'm basically, let's say I put in my doxy. Let's say I get 100 cc's out. I put 50 of doxycycline in, okay? And that's 50 cc's. And for the life of me, they hand me the vial. I don't even remember the dose. I think it's probably 10 units per cc, but please don't quote me on that. You look at the papers I've written. I don't remember at this point. They literally hand me the vial, so I don't really remember at this point. But nonetheless, so let's say I put 50 in, I let it dwell, and then I open it for 4 hours. I leave it in there for 4 hours. I open it for 4 hours, and I get 60 cc's out. I'll put 30 cc's back in. When that number drops to like 10 or 20, I'm clearly just replacing my doxycycline with no extra lymph coming out based on volume. I cut the catheter and pull, and we're done. And for these giant abdominal malformations in kids, you can save them or multiple surgeries. And the problem with operating on these is whenever they operate on them, they always come back because they're like tumors. They regrow. They don't go anywhere. They don't metastasize, but they will regrow. And that leaves you with scar tissue and terrible tissue planes to work through for sclero. If it's macrocystic, I can get a needle into it, but it's not large enough to leave a catheter. I'll just drain each of the cysts and replace it with 40 to 60% volume of doxycycline back, okay? And then just send the patient in overnight for pain control and then let them go the next day. If it's microcystic, we get into some interesting issues, right? So systemic therapies like sirolimus, rapamycin work great. Tons of papers on that. If they're kind of local, you can use topical sirolimus if it's on the skin. And there are some companies now that are looking at making that not, something you make in a compounding pharmacy, but there are companies looking at sirolimus creams that will come out with a standard dosing. If they're microcystic and they're deep, I don't try to get a needle into it. What I'll do is I'll get a needle in between the cyst and the interstitium, and I'll flood the area with bleomycin liquid. So bleomycin is a different type, like doxycycline and bleo are a type of atypical sclerosins. Doxycycline is both irritative and it's a VEGF inhibitor. Doxycycline is a chemo, and we use it a lot now in venous and lymphatic malformations that either I can't get a needle into, microcystic lymphatic, or things that are in spaces where you don't want to have a lot of swelling and post-procedural swelling like you would from alcohol or detergent. And that'll be in the head and neck or in the hand, in the forearm, or right next to a nerve like behind the knee. And then for microcystic, I'll lace the area with bleomycin. Bleomycin, unlike doxycycline, I'll check the lesions in doxycycline and have the patients rescanned at 6 to 8 weeks. Bleomycin, I wait at least 10 weeks, if not 12, because it takes longer to work. And when you look at it, well, I'll tell you about that for venous malformation, but when you look at them, they act in a vastly different way. So that's macro and microcystic. If it's a lot of lesion, I will put them on a systemic therapy first. If it's clippultrinane with kind of a mixed lymphatic and venous malformation, systemic sirolimus or rapamycin, same thing, works amazingly well and can really help these lymphatic lesions kind of melt away. So that's lymphatic. Venous is fun. So venous is most of the practice, right? 90% of people have venous malformation. It's all sclerotherapy for me. My first line agent is alcohol. My second line agent, which is similar to alcohol, are the Sotradecol detergents, foamed. And I'll tell you when I use that versus the other. And then bleomycin is my agent for sensitive areas or for people who can't tolerate pain and swelling. So alcohol, gold standard, terrifies everybody. Don't be afraid of alcohol, all right? Alcohol is your friend. Every fraternity boy in college knows alcohol is your friend. No, I'm just kidding. Alcohol shouldn't be taken that way, but alcohol delivered to a venous malformation should not scare you. You got to use the right dosing, and you got to do it carefully, and you've got to be in your lesion without being out. So you'll never see me in any of these putting in a catheter except for the doxy exchanges. This is needle in, confirm blood return, do a venogram, and then treat, right? and then I leave contrast in the lesion, and then I do what I call negative contrast venography, where I've done my venogram, I immediately switch over to my alcohol, and I deliver it, and I wash everything out, and when everything's clear, I stop, okay? And alcohol for me is dosed at a maximum dosage of 1 cc per kilogram, and a maximum per 5-minute dosage of 0.1 cc's per kilogram. For Sotradecol, 3% liquid, you cut that volume in half, but I never use liquid Sotradecol. I only use foam Sotradecol.
So how do you moderate that, your dose when it's based on cc per kilogram, but these are different size lesions?
Yeah. You hope you don't have a little baby with a lesion that's the size of a watermelon is what you hope.
Yeah.
That's a good question, right? That's when I use Sotradecol. So Sotradecol, like alcohol, thrombosis, endothelial death. Bleomycin causes DNA damage and slow necrosis. The alcohol and Sotradecol cause thrombosis, inflammation. You damage it, and then it heals. Sotradecol can be foamed. So I've never gotten to a maximum dose of Sotradecol because you make a big foam out of it. And right. I foam it differently than everybody. I have a very specific foaming technique where I use, 2 of Sotradecol, 1 of Lipiodol, and then 4 of air. Other folks would be very upset by the use of Lipiodol because it's supposed to decrease the efficacy of the foam, but realistically, it really makes the foam stick around a little bit longer. And when you foam bleomycin, which I do, by the way, I foam my bleomycin as well, using an albumin foam, right?
Yeah, that's how I do it also.
That was reported by Bill Shields at one of the original ISFAs I went to, and then we waited for him to publish, and he didn't publish. Unfortunately, he passed away from pancreatic cancer, so we published that work, and we were only allowed to give him an acknowledgement because he wasn't alive to sign the... JVR at the time was a little rigid. But so I use foam bleomycin. I'll use liquid when I don't need to foam it, right? And that's 0.5 units, not international units, per kilogram of bleomycin. Actually, I actually quoted you wrong. It's 1 of Lipiodol, 2 of Sotradecol, 8 of air is how I do it.
Got it.
8 of air. And so you can get a lot of foam there. And sometimes I'll swap the Lipiodol and the Sotradecol if I have a huge lesion in a small child. So I had a child with a huge chest wall lesion, and I couldn't even foam enough Sotradecol to get it in there. So I just gave more Lipiodol and less Sotradecol. And so I made it kind of a more Lipiodol-based foam with enough Sotradecol to be effective. But generally, I don't muck with the foam. I do the same foam every time. And so how do you dose alcohol? So, I'll try to cover as much of the lesion as possible, and then I'll just stop treating and bring them back another day. I will say in my practice, I recheck the needles after 15 minutes. If they're still bleeding back, I will retreat. So I always save about 25% of my dose for the last second treatment, right? So for the second treatment.
You bring that up, needles. How do you determine how many needles you need to treat a venous malformation?
I just keep putting needels in until I've covered the lesion.
And that's based on the contrast injection.
That's based on ultrasound, my venogram, and then, so it's ultrasound needle in, venogram through the needle, right? I don't put catheters in any other place unless I'm trying to flush the deep veins. Then I'll put a catheter like in the foot, put a tourniquet up periodically, and inject and pump the calf to move the vein. I do use pneumatic cuffs above the lesion, not clearly in the head and neck, but in other places. Well, like if it's in the knee, I'll put it I'll put it around the thigh. It's really not good to make your patient's cranium ischemic. You don't want to cause that. But I will use Trendelenburg for that. Right? I'll put them in a steep trendy. So I'll put them head down for that. And so what I'll do is I'll do an ultrasound, and I like to plan my procedure. So I look beforehand. I have the patient mark with their finger a single X with one finger. They can't go like this. One finger on the part that hurts the most, and I have them mark 1, 2, 3, 4, 5, 6, and then put their hand around the whole thing. And if it's something small, 4 or 5 needles will do it. You'll look afterwards with ultrasound. If you see lack of compressible malformation from alcohol, foam from either bleomycin or Sotradecol covering it, then you've treated that area and you move on. I always start deep and move superficial for that reason. And I'll work my way through the lesion, top to bottom, side to side. I let the resident pick the way they want to go. They learn very quickly that if you put the needles in from the wrong side, you block your ultrasound soon enough. So they learn pretty quickly how to map the lesion. I think my max was 18 or 15 needles. That's a long procedure. all under anesthesia because this stuff really hurts, adult and pediatric. And you don't want things to move. There's nothing worse than you have a needle deep in someone's hand or in their face, or I'm doing retro-orbital malformations now, and someone jerks and you're like, what the hell just happened there? So I do a lot behind the eyeball now. I shouldn't say a lot. I seem to be the referral for a lot of those.
I think that if you do any, it's a lot. And
I'm 5
how do you
down.
access this? That is a lot. Like, one is a lot for me.
So first of all, I put on my big boy pants coming in the room, and I usually wear a diaper too, because it's definitely not a fun experience. So you either access medially or laterally, and I use ultrasound to find the globe, and then I go and hit the medial wall or the inferior wall of the orbit, and I work my way back.
Oh my God. And
the last one was so far back, I do some with Interventional. So Majid, Ferdinand Hui, who's now out in Hawaii, and I did a couple behind the eye. And to be fair, the first one I had him put the needle in because I was having trouble just looking at it as the needle slowly went back behind the eye.
100%.
But Majid and I just did one under CT where I'm doing CT, ultrasound, and then sometimes just fluoro. You just find the eyeball and just don't hit the eyeball.
Jesus.
It's a little gross, but you use bleomycin.
I bet it's really awesome when you're done.
Well, usually watching the resident's eyes get bigger and bigger and bigger through the case is kind of fun too.
I bet. Man, that's wild.
Yeah. But we do some, I do a bunch of head and neck. So I do a lot of tongue and oropharynx. Some of them I do with ENT where we put the needle way, way back. And watching how alcohol works versus like bleomycin is really fun because alcohol immediately turns red and swollen and blanches a little bit. Sotradecol does the same thing, but bleomycin turns dark purple. It gets necrotic. It's really neat to see. And then I do a lot of tongue where we actually take the tongue out of the mouth with a zero suture and kind of tie it to the patient. And then we put needles into the tongue and work our way through the tongue with bleomycin as well.
You know what? The one that I sent that I just said needed to call your clinic was a tongue, and I'm glad that I did that.
Well, I mean, sometimes they go wrong, but usually they go pretty right. So yeah, so that's sort of the treatment. And then we haven't done AVMs yet. That's a whole other conversation, but I can do that. So
let's do it.
Look, but we think about it this way, right? Hemangioma, you're going to ablate. Lymphatic malformation, you're going to treat either with bleomycin or doxycycline with either catheter-directed kind of exchanges over a number of days. You put a drain in the patient, or direct stick. For microcystic lesions for lymphatic, bleomycin infusion, liquid's fine. Venous malformation, dealer's choice, direct stick, alcohol, sotradecol foam, or liquid or foamed bleomycin, depending on where it is. AVMs are where things get creative. AVMs are all about, like, those are the cases where, those are the ones that keep me up at night. It's not the pulmonary AVMs, it's these AVMs.
Yes.
Because they all are different. And so how do you treat them? There are many classification schema. The one that's most important to me is how many draining veins are there? If there is a single large draining vein, then you can do this through a direct stick venous approach or through a transvenous approach. And if you take out all the outflow, the inflow will die over a week or so. In fact, it'll sometimes die right in front of you, okay? And so I've done a few of those from the venous approach. My colleague who does them with me and in parallel with me loves that approach. Like, if he can find a way to do it from the veins, he'll do it, because the arterial approach is frankly long and painful. So yes, right?
So tell me how you do it from the venous approach first.
Well, so first I do a mapping angiogram. I very rarely will treat the same session I do a mapping angio, because I want to get my ducks in a row. I want to think this through. I want to look at the 3D anatomy. I want to bring in the necessary equipment and reps, because let's be fair, I don't have enough on the shelf to treat some of these big ones without burning through all the stock.
I've also found that it's like very often not what I was expecting. Even if I have good quality imaging, I'll get in there and I'll map it out. I'm like, oh, Jesus, like, did not think it was going to look like this.
Yeah, 72 different arteries feeding into it. And by the way, so let's do the veins. So vein approach. My favorite, if I can, is to direct stick the vein. I'll get arterial access so I can see the thing, running and feeding through. I'll stick the vein. Ultrasound can do it. CT, if you have a hybrid room, will do it. I will then coil, glue, sometimes I'll put a little alcohol behind my coils. It's about stopping a river. all right? And it's the outflow. So as long as you have control, I'll start to coil, and then I will, if I have a coil pack that's sort of formed, I might use a little bit of onyx. I may use glue. I don't love glue because you have to take everything out quickly. So I might use a little onyx to finish. And sometimes I'll even put a little alcohol in my coils and see if I can get the vein to shut down. And the theory there is you're killing off the nidus on the vein side, which is where it's believed a lot of the AVMs are going to grow from, is from the venous kind of mutations. But really what you're doing is I'm just shutting off the pipe. And if you can't get anything out, nothing is going to come in anymore. So that can be great. But I can also be cutting Benson wires and putting them in there if it's big enough, right? Like giant coils are sometimes necessary, right? So that's that approach. And sometimes you can get down, let's say it's a pelvic AVM and it drains into the internal iliac vein. You can come down that way and come in that way too. And so then you'll see catheter on this side, which is the artery giving me my map. And I've come in from the venous side the other way, and then I start packing it with metal. And that works really, really well. I'd say 15% of my AVMs I probably can do that way, some venous approach. Then you have the ones you can't. So if there's a direct nidus, you can stick it directly after you've mapped it, and you can, deliver alcohol or onyx or glue. Very rarely do I do that because I generally don't find that works that well. A bailout move that I'm seeing coming out of other countries, which I think is brilliant, and I wish I'd thought of it, is perinidal injection of bleomycin. So when you don't want to do the arteries because the arteries potentially feed important things like fingers, people have been injecting interstitial bleomycin. It seems to work. I've never done it, but it's been reported. There's a new thing called electrosclerotherapy coming out of Germany and Amsterdam right now, where you do electroporation after bleomycin administration. Those are sort of the out there. The standard approach is transvenous or transarterial. So transarterial, whatever it is, I try to get as much support out as possible. It can be a groin sheath, a long sheath, a macro catheter, and a micro catheter. And I try to get as close to the nidus as possible with the knowledge that if I can knock out as much of the nidus as possible, I don't have to take out every feeding artery. The one thing you'll never see me do, coil or glue or do anything to ligate an artery that's not in the nidus, because when you cut off those arteries, the feeding arteries, and don't kill the nidus, they just regrow more arteries from other places, and it's a disaster. So I'll get all the way to the nidus, and then I love alcohol. I'll use alcohol here, dose the same way. Sometimes now I've been using a lot more. I've been using an occlusion balloon, like a little scepter, and then following that with onyx, and then really filling the nidus by pushing onyx out and not worrying about making a plug because I've made that plug with the balloon, and I'll really pump onyx into the nidus. That works really, really well as well. I've used glue in the past. I tend to not use glue as much anymore. And by onyx, I mean any EVOH product. It could be lava, it could be onyx, it could be any of those, but it's EVOH. And then, if you're using occlusion balloon technique where you do your mapping, get your occlusion balloon out there, and then fill it with onyx or EVOH of some sort, we've done whole facial malformations where there were 4 feeders in 3-4 hours and been done and never had to bring the patient back again. So that's the beauty of being able to do that, is you're not like waiting for a plug, waiting for alcohol to work. Alcohol you deliver in the same kind of dosing as for venous malformations, 1 cc per kilogram max, 0.1 cc's per kilogram per 5 minutes, and you'll kind of just wash the alcohol through the nidus and then check to see if you have occlusion. So, those are where things get creative. So everything's different. I've never done 2 patients the same with AVMs.
Totally.
And now there's new medication for it too. There's drugs like Apellicib and Trametinib. Apellicib is for PROs. Trametinib is what people have been using now for a MEK inhibitor for AVM. So I've been sending some patients out to oncology to get Trametinib for big AVMs too.
When you're direct sticking these, how are you targeting the nidus? Like, how do you know this is the spot where I'm going to stick? And same when you're, going from a transarterial approach, how do you know you're close enough to the nidus?
Direct stick of the nidus, you have to be very clear that you're seeing the nidus, that you've already mapped this thing out, and that when you inject contrast, you're seeing what you've seen on the prior imaging, right? So I've done the angiogram. I know what the nidus looks like. If I then stick it, I do my arteriogram through the needle, right? And it doesn't look like the nidus, I'm not there. If it looks like it, then I know I'm there. And I know I may have to do it in 3 or 4 sites if necessary. Transarterial, again, I've mapped this out before, so I know where my arteries are. I know what's feeding what part of the nidus. I try to take the biggest one first and get as much of the nidus as possible, knowing that as you start to shut those down, the other feeders will start to shut down too. And so how do I know if I'm close enough? If I'm using alcohol, I have some distance to work with. If I'm using onyx with a balloon, I have a little bit of distance. If I'm using onyx or glue without a balloon, I don't have much distance to work with at all. So I can be right in the nidus. I can be just adjacent to the nidus. I'm never that far from the nidus. I'm always within a couple centimeters of the nidus.
Particularly for the high flow vascular malformations, when do you follow these patients up and how?
Yeah, so I have a very regulated treatment. And by the way, for fistulas, it's a 1-to-1. You can use a plug. You can use coils just to close the fistula, right? I like a good plug for that. How do I follow these? So I can tell you everybody gets a 1-week visit for their first treatment. Almost everyone gets admitted overnight except for bleomycin cases where people have done this many times and they want to go home. They come back in a week for a virtual visit, a week or 2. And then generally I follow people with an AVM with imaging at a month. But because of the way our system works, it usually ends up being more 6 to 8 weeks, which is my standard follow-up, or 12 weeks for bleomycin in clinic. And then those patients come back once they're at a place that they're happy. So I do quality of life metrics. We make sure that they're clinically getting better. Once they're at a happy place, and I always tell people we're not looking for perfection. We're looking for better, much better. I can take you from a 9 to a 4. I can take you from a 6 to a 1. I can't do anything with 1. Like if you're at a 1, have a great time, right?
It's probably important for a lot of these.
All of them, really. Really, like you were not looking for perfection. And so I will then follow them annually. And then when things are really quiet and we know that malformations are going to have significant growth periods during puberty, during pregnancies, and we like to get them under control before that. But once things are quiet, I may see them every 3 to 5 years. And I usually do imaging without contrast after the first few MRIs, just because it just isn't unnecessary to keep doing it over and over again.
Yeah.
And then if people have problems, they call the clinic and they come in earlier. So again, it's sort of as a tapering off where it's very, very soon after to make sure no complications, 6 to 8 weeks to 12 weeks to see how do we do. And then we would repeat as necessary. And then once we're stable annually, and then annually becomes every 3 to 5 years when their lives become stable and the lesion's proven itself to not have come back. Yeah.
Awesome. Is there anything else that's important to cover that I haven't asked you?
Yeah, I would say 2 things. One is realize these lesions now are all being genetically characterized, right? They're all getting cancer genetics run on them to see what are the mutations and what drugs can help. And honestly, I'd say 20% of my clinic now is getting some type of systemic therapy before they get to me. Yeah. I mean, I'm happy to be put out of business for these big ones. I mean, these can be horrible. They can be whole body malformations, unilateral malformations. We didn't even talk about syndromes today, right? So they get really complicated. So one is, if you don't really know what you're doing, right, ask for help, refer them to centers, because you can do damage to patients if you're not confident and you don't know what you're doing. Like these don't really, other than AVMs, not a lot of these don't cause me a lot of anxiety at this point. To me, it's sort of like a routine procedure, and that's what you want to be. You want to be the 12th person I've done that week, not the first person I've done in a year. So you really want to be careful. But I will tell you, for small lesions, if you've been properly trained, you can handle this. Just if you need to ask questions, ask an expert. If that means calling up someone at CHOP or Children's or calling someone like me, that's totally fine. I'd say my fellows and former residents and former fellows, I get 1 or 2 calls a month to say, hey, what would you do with this? Even from some of my co-fellows back from the 2000s who are my classmates will call me and say, what do I do with this? Sometimes I'm like, well, why don't you just send them to me? But most of the time I say, this is the steps you want to take. And just be careful. Follow the guidelines, follow the rules, make sure you're properly diagnosed and classified. If you can send it for genetics, and you're in a center that does that, do that. It's not so easy always to get genetics from these. And realize that I suspect that other than small and local lesions, I think in 15 years, IR will have a minimal role. Like we will be the people you bring in at the end to clean it up or to deal with the things that drugs can't handle. So I think that's sort of where we're going to live. I tell people, don't be afraid, stick to your training. You don't need to use the force, just use good imaging, use the right drugs, use the right medications, and kind of know what you're doing. And don't hesitate to put safety measures in place, like anesthesia when you need it. But always, if you need to ask for help, that's what the centers are here for. Like, this is what we do for a living.
Fantastic. Well, Cliff, thank you for sharing your time and expertise with us. This is great, as always. I look forward to the next one.
I look forward to it, too. I think it's already on the books. So,
Yep.
Good to see you.
Thank you guys so much for tuning in. If you haven't already, please be sure to subscribe, follow, and rate the show. Let us know how we're doing and what we can do to improve it. We work really hard at making this a valuable resource for you, and we want to continue to do that. So give us your feedback. Lastly, tell a colleague about the show. We think they'll like it. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Chris Beck, and co-hosts
Ali Behetti,
Michael Barraza,
Sabine Don,
And Aaron Fritz.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe DeGrazio,
Josh Spencer,
and Jaden White.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.